All right, let's get straight into Step 2 CK Obstetrics. We are focusing strictly on diagnostic criteria and the absolute next best step in management for labor and delivery scenarios.
Here is the roadmap for this explainer. First, preterm labor and triage. Second, PPROM and chorioamnionitis. Third, fetal heart rate tracings. Fourth, decelerations and resuscitation. And finally, labor progress and arrest.
Section 1. Preterm labor and triage. Thresholds and interventions.
So what is the diagnostic cutoff for true preterm labor? It strictly requires regular contractions causing visible cervical change before 37 weeks gestation, assuming membranes are intact. On the left side here, false labor presents with irregular, infrequent timing and absolutely zero cervical change. The pain might even be absent or super mild. But the second you see cervical dilation on an exam, paired with contractions of increasing intensity, you've crossed the threshold. You're now looking at true latent or preterm labor.
Now here is a crucial pivot point. Maternal instability or intraamniotic infection immediately shifts the algorithm toward delivery completely regardless of gestational age. If you have maternal instability, fetal distress, fetal demise, or an intrauterine infection, your next best step is immediate delivery, no waiting around. But if the mother and fetus are stable, you manage this based strictly on gestational age cutoffs.
For a stable patient before 34 weeks, short-term tocolysis is the move. This allows time for the benefit of antenatal corticosteroids to kick in. You need to memorize these hard thresholds. Before 32 weeks, give antenatal corticosteroids, penicillin for GBS prophylaxis, if indicated, indomethacin for tocolysis, and magnesium sulfate for fetal neuroprotection when birth is expected. Keep in mind, indomethacin is strictly contraindicated after 32 weeks due to the risk of premature fetal ductus arteriosus closure and oligohydramnios. So between 32 and 34 weeks, you switch your tocolytic to nifedine. Just remember that nifedine can cause arterial dilation and reflex tachycardia.
Section 2. PPROM and chorioamnionitis. Rupture and infection protocols.
Okay, PPROM. That is preterm pre-labor rupture of membranes. This happens prior to the onset of actual labor contractions and before 37 weeks gestation. Risk factors to watch out for here include genitourinary infections, a history of prior PPROM, and antepartum bleeding. To confirm that rupture on a sterile speculum exam, you're looking for clear vaginal pooling, alkaline amniotic fluid that turns nitrazine paper blue, and that classic microscopic ferning pattern. Now, this is a huge rule. Avoid digital cervical exams entirely unless delivery is imminent. We really want to prevent any ascending infection.
Under 34 weeks, an uncomplicated patient gets expectant management. That means latency antibiotics, corticosteroids, fetal surveillance, and magnesium sulfate if they're under 32 weeks. But if there are any signs of interamniotic infection or fetal or maternal compromise, your next best step is immediate delivery and infection treatment. Tocolysis is absolutely not used in PPROM. Once you hit that 34-week mark, expectant management is out the window, and you proceed straight to delivery, plus GBS prophylaxis when indicated.
Moving on to chorioamnionitis. Risk factors here include prolonged rupture of membranes, specifically over 18 hours, prolonged labor, repeated vaginal exams, and internal monitoring. To officially diagnose it, you need a maternal fever plus at least one of the following: fetal tachycardia above 160 beats per minute, maternal leukocytosis, or purulent amniotic fluid. If you make that diagnosis, start broad-spectrum IV antibiotics right away, like ampicillin plus gentamicin, and move to immediate delivery. Induction of labor is the standard if the fetal tracing is reassuring. A cesarean delivery is strictly reserved for standard obstetric indications.
Section 3. Fetal heart rate tracings, categorization and assessment.
Let's rigorously define these categories. A Category 1 tracing requires a baseline of 110 to 160 beats per minute, moderate variability, and no late or variable decelerations. Early decelerations and accelerations, those are optional. On the other end of the spectrum, a Category 3 tracing is an absolute emergency, requiring urgent intrauterine resuscitation and delivery if unresolved. It's marked by absent variability, paired with recurrent late decelerations, recurrent variable decelerations, or severe bradycardia. Absent variability maps directly to fetal hypoxia or the use of central nervous system depressants. Minimal variability, meaning 5 beats per minute or less, can indicate a temporary fetal sleep state, prematurity, or hypoxia. On the flip side, baseline fetal tachycardia, which is anything above 160 beats per minute, often points straight to maternal fever and intraamniotic infection.
If you see a smooth, undulating, sinusoidal pattern like this, it indicates severe fetal anemia. No questions asked, this automatically classifies the tracing as a Category 3 emergency. It requires immediate intrauterine resuscitation and delivery if unresolved.
Section 4. Decelerations and resuscitation, tracing etiologies and interventions.
Visualizing the nadir of the deceleration relative to the contraction peak is the definitive way to identify its type. Look at the top tracing. An early deceleration is symmetric, with its nadir corresponding perfectly to the contraction peak. A late deceleration has a delayed nadir occurring after the contraction peak. A variable deceleration is abrupt, dropping 15 beats or more in under 30 seconds, completely regardless of the contraction timing.
When you see these, apply the strict if-then logic. Early decelerations mean benign fetal head compression, requiring no intervention. Variable decelerations indicate umbilical cord compression. Your first step is maternal repositioning, followed by amnioinfusion if they are recurrent. Late decelerations point to uteroplacental insufficiency. For these, initiate intrauteral resuscitation immediately. Give oxygen, stop uteral tonics, treat hypotension, administer fluids, and reposition the mother. If that doesn't resolve the tracing, you proceed to delivery.
An abrupt, prolonged deceleration with no return to baseline demands immediate evaluation. If you identify an umbilical cord prolapse where the cord literally delivers through the cervix ahead of the presenting part, the immediate next best step is an urgent cesarean section. And while you're prepping for the OR, you must manually elevate the presenting fetal part to relieve that cord compression.
Section 5. Labor progress and arrest. Active phase management.
Active phase labor really kicks off around 6 centimeters of dilation. Now, active phase protraction happens when cervical change is slower than expected, with inadequate contractions meaning less than 200 Montevideo units in 10 minutes measured via an intrauterine pressure catheter. The next best step here? Administer oxytocin. Active phase arrest, however, is defined as absolutely no cervical change for 4 or more hours despite adequate contractions. In that case, the definitive next step is a cesarean delivery. Let's quickly cover a few other highly tested delivery mechanics. For post-term pregnancies, induction of labor is generally indicated between 41 and 42 weeks to prevent uteroplacental insufficiency. Operative vaginal delivery strictly requires full dilation, ruptured membranes, an engaged head, a known position, an adequate pelvis, and the ability to perform an emergency cesarean if things don't go as planned. Dealing with a breech presentation, attempt an external cephalic version after 37 weeks if the fetal status is reassuring and there are no contraindications to a vaginal delivery. Finally, if you encounter a turtle sign after the head delivers, that indicates shoulder dystocia. Immediately call for help, instruct the mother to stop pushing, and initiate the McRoberts maneuver and suprapubic pressure. Do not use fundal pressure. If it's still unresolved, move to posterior arm delivery, rotational maneuvers, all-force positioning, or the Zavanelli maneuver to prevent severe complications like a clavicle or humerus fracture, Erb's palsy, Klumpke palsy, hypoxia, or postpartum hemorrhage.